valuable resource for health, but in many situations, that is not very evident. 2006 to 2015 was declared as the decade of human resources for health. I guess today celebrated as what? World Day for Mental Health or something like that? Right. That's a big issue. Big and getting bigger. And of course, there are many healthcare workers who have mental health issues that are treatable, that can be dealt with. And so we must encourage those amongst us who may feel a little different to seek help. Now, for some time now, a number of countries have been experiencing crucial shortages of healthcare personnel. Jamaica and the Caribbean, no exception. Here in Jamaica, we lose mainly nurses, but there are a number of doctors that we are losing as well. As a matter of fact, agencies from developed countries like the United Kingdom, United States, probably Canada to a lesser extent, they actively recruit from Jamaica. So if those countries are recruiting actively from Jamaica, it tells us something, that our product is good, our training is good. And one of the things that create healthcare worker shortages in a number of these developed countries is that a number of professionals do not find it attractive to go into academia and train their own. The pay is not good enough for them. So they prefer to practice rather than go back and assist in training their peers, and I can understand that very well. But since as a country we are spending so much to train our people, I often wonder why there's not some discussion in terms of arranging with these countries how we can train for them right here in Jamaica, rather than waiting for our people to graduate and then try to lure them away. Right? Certainly we can't stop people from going if they want to go. But when they go, they would have left a problem here. And I'm just wondering how to allow it if we couldn't discuss with them. Since they need nurses, why can't we establish a nursing school right here in Kingston to train foreign nurses and send them back home? That would bring some money to us, and that would help to save on our nurses while we try to improve situations for them locally. And that's the answer. That's why people leave. People could be comfortable here. By come down here, earn a salary that you can buy a house and buy a car and live a decent life. That's what people want to know. And if you're a professional and you can't do that in your own country, then something is wrong. Right? Something is wrong. You spend 7, 8, 10 years in university, have all kind of degrees, and then you can't then you can't live in your own country. That's disgraceful. Alright, so we're looking here at the density of physicians globally, and it's the total per 100,000 population, and that's for 2018. And you can clearly see that in most areas, the number of physicians that we would need per 100,000 population is way below what would be ideal. And so there is a global shortage of healthcare workers. Some countries don't really have a shortage since they attract many of these workers from different parts of the world. All right. So in terms of hazardous exposures to healthcare professionals, just to give you some examples of what has been going on. So Canadian workers, for example, one study, were 1.5 times more likely to miss work due to illness or injury than other workers. Each year, about 3 million healthcare workers are exposed to blood-borne pathogens due to needle stick injuries, and the three main diseases they are exposed to are HIV and hepatitis B and C. Those are the three main blood-borne pathogens that healthcare workers are exposed to. You can see the numbers there. I don't know if you ever heard of SARS. Ever heard of disease SARS? Right. It came about in the early 2000s, about 2003, 2004. More than 20% of global SARS cases were healthcare workers, and many of those would have been doctors. In Botswana, for example, in Africa, 17% of the healthcare workforce died from AIDS between 1999 and 2005. 17% of the healthcare workforce died from AIDS. Right? We're not hearing a lot about HIV anymore, but certainly HIV is not a disease of the past. And if we're to believe statistics from the ministry, it tells us that about 6 out of every 10 persons who are HIV infected don't know they are HIV infected.
That's crazy.
And the best news now for anybody who is HIV infected is to know that they are. Because if they know that they are, then they can go on treatment. Because current treatment for HIV reduces the viral load to undetectable amounts. And in some cases, people with HIV now, based on their treatment, can have sex without the risk of spreading HIV. So that's how advanced the situation is. So there is no reason why somebody in this country or anywhere should have HIV and don't know about it. Because once it progresses to AIDS, then that's it. So the important message for everybody is to know your status. And even if you are positive, it is still good news. Because you can go on treatment. Without you knowing, then you're going to stay there one day until you just start to get sicker and sicker and sicker. Right? Alright. Now, about 90% of the world's TB cases are found in hospitals in developing countries. Now, think about that. The countries with the largest number of TB cases are China, India, South Africa, Brazil, and I think Thailand. Right? 5 countries have most TB cases. It's important for you to know as well that roughly 1 in every 4 persons globally are infected with the TB germ. 1 in 4, according to the WHO. So we have all of these people with latent tuberculosis. The germ lying there dormant in the lungs, and about 5% will develop TB at some point in time, whereas 90% or more will never develop full-blown TB. But with the HIV pandemic, we find more and more people with HIV being diagnosed with TB. And in most of those cases, it's not that they just contracted TB. They had TB there lying in their lungs for years or decades. But because HIV damages the immune system, it now makes it possible for TB to come to the fore. So right now TB is the most important infectious disease, which is spreading. So TB is not a disease of the past, right? So 54% of healthcare workers in these countries, developing countries, are estimated to carry latent TB, right? And the rate of active TB is higher among healthcare workers from developing countries than in the general population. Now, there is something known as the healthy worker effect. And the healthy worker effect is a comparison of the mortality rate from a particular disease in workers compared to the general population. And typically, the mortality rate from a particular disease is lower in workers than in the general population. Because workers are selected, workers are screened when the workers have to go pre-employment medical examination. So the healthiest people are always found in the workforce. So if you have a situation where healthcare workers are getting sicker than people in the general population, it means there is something at work, or there's some workplace exposure that is killing them. Right? And that is the problem. Anytime you're going to find workers start to get sick and die from a particular disease more than the general population, it means that there's something at work killing them. Because workers are much healthier than the general population. COVID, we all saw what COVID did to us. Some of us experienced it as well. I never got COVID, but I lost two good friends to COVID. One was a bit stubborn. He was a man of great means. He had some amount of wealth. He was intelligent, but he was waiting for a vaccine from a particular country. I couldn't get him to take the vaccine because the one he wanted was not available. And I went for my first shot, I came back, I told him. I went for my second shot, I came back. I told him. Went for my booster, I told him. And then one morning he called me and told me he was in the University Hospital of the West Indies with COVID. Of course, he was on the older side of life, so he had comorbidities. Right? And we spoke on the telephone. And one day I just decided that, I'm just going up to the hospital. Right? So I found the ward he was on. I was not allowed to go on the ward, of course. And I was there thinking to myself that here it is, I'm at this hospital and my friend is inside there, sick, and I can't see him, right? So I did the best thing I could. I took out all my business card and I wrote a message on it and I asked the nurse to give it to him. I don't know if he got it. But within a few days, he was dead. And that's a death that could have been prevented. Right? So COVID has done all kinds of things to all kinds of people. Many have been lucky, they resisted vaccination and never got infected. I put that down to luck. Right? But many people died that could have been with us today. Right? So of course many healthcare workers were affected by COVID-19. We lost many in Latin America and the Caribbean. because especially at the beginning of the outbreak, they didn't get appropriate personal protective equipment. And even among healthcare workers, some were hesitant and resistant and did not take the vaccine. One of the things that has helped us as a country, one of the things that have helped people like you and me when I was your age and younger to survive was vaccination. We have an effective program called EPI, Expanded Program on Immunization, where school-age children have to be properly immunized before being admitted to school. And it was working well. And then came COVID-19, and many people decided that all of a sudden vaccine is no good. And they spread a lot of rumors, very influential people at that. And so created doubts in the minds of people. Well, I took the decision that it would be better for the vaccine to kill me than COVID-19. Right? That's what decision I took. Right? So remember now, as budding doctors and healthcare workers, there are vaccines out there to protect you. Certainly there's hepatitis B vaccine, which every medical student should be vaccinated against hepatitis B. I don't know if all of you are. But I'm just saying that there are vaccines out there that will help you against occupational exposures. Alright? Alright, so we got a hit here in the Caribbean. Things are improving, but don't think we are over with COVID-19 just yet. I don't think we are, and it's going to take some time. So let's continue to practice the precautions that we know very well. So there were some headlines in Jamaica. Healthcare workers worried as COVID-19 cases spike. Nurses on sick out amid surging COVID-19 cases in hospitals. And there are other headlines. All right. In terms of current issues in biosafety, of course, we have acute respiratory diseases, or ARDS. They are the bloodborne pathogens, which I mentioned. Most notable are HIV, hepatitis B, and hepatitis C. Tuberculosis, bioterrorism, which we will discuss in our disaster management sessions. Legionellosis, which has been associated with air conditioning in certain buildings that were not maintained. As a matter of fact, the disease became known as legionellosis because it first struck when the American Legion, they met at a hotel, I think it was in Philadelphia, and many of these people got sick and were hospitalized, and they discovered that here we had this new pneumonia-like illness, and they called it legionellosis after the people who first got it. Right? I've discussed with you building-related by aerosols, and there's that organism which is new, Listeria, Basidia. I want you to read up on it. All right. In terms of the healthcare setting, though, there is a characteristic absence of a good safety culture. Right? So in many cases, occupational safety and health is sometimes viewed as less important than patient care. Of course, patient care is important. That is what you are trained to do. But you cannot neglect your own occupational safety and health issues. Because as I said to you, If you're not well, you can't provide patient care. It's as simple as that, you know. It's as simple as that. For you to provide the best patient care healthy, the best patient care possible, you yourselves and your other colleagues out there have got to be healthy. And there are many occupational exposures that can make you sick. So, often healthcare workers discuss prevention and quality care for patients, but not for themselves and their colleagues. Right? So more often when you meet or when you see doctors meet, the main concern is what we can do to improve patient care. That is right. But you must also take some time to think about your own situation. What are the exposures you are experiencing? Can they make you sick? Worse, can they kill you? Because some of these exposures do kill. Alright? And I'm not trying to scare you, I just want you to be vigilant as you go about practicing. You have to take care of yourselves. You must be healthy. If you're not healthy, you can't provide health care for others. And don't run the risk of getting sick while delivering health care. Many of these conditions are preventable. Just that sometimes we're not alert enough, we're not vigilant enough, and we have this kind of superhuman perception that they are the patients, they get sick. We are the doctors, we don't get sick. It doesn't go like that. Remember I told you about the healthy worker effect. So you're going to the doctors. You enjoy good health because one, you're young, and two, you're screened or you still need to screen yourself. So you're going to be as healthy as anybody can be in the population. But it doesn't mean that you should expose yourself to situations that could compromise your own health and safety. So many healthcare professionals have false belief that they are immune to work hazards. The super being syndrome, as we call it. We need a culture of putting on one's own oxygen mask first before helping others. Right? So when you fly, you're advised that if there's an emergency, you need to get on your own oxygen mask first before you try to help others. This is something I want you to think about. Right? So there's need for the inclusion of awareness about health hazards in healthcare educational programs. You're fortunate you're getting that kind of input. I've been writing to people for some time, and I've been looking at teaching of environmental health and occupational health in medical training programs globally. And I'm almost at the verge of concluding that our program here at Mona provides the greatest number of hours of exposure to medical students in environmental and occupational health. And that's good. All right, so we spoke about acute respiratory diseases. These are diseases that affect upper or lower respiratory tract, usually of an infectious nature, and some may be asymptomatic, while many are symptomatic, and they're caused by a number of factors. Typically, ARDs spread through person-to-person contact with rapid onset of symptoms. Okay, I'm going to stop now. Good. Adequately ventilated single room is a single room or side room on a ward in which there is 12 or more air changes per hour without control of direction of the airflow. Alright, so airborne precaution or airborne infection isolation room. This is where you have 12 or more air changes per hour. It's negative pressure, and you need to understand the concept of a room being negatively pressured or positively pressured. Right? If you have a room with a TB patient, TB is transmitted, it's an airborne infection, right? So you wouldn't want, when that door is open, the contaminated air that may be inside rushes outside. You don't want that to happen. So that room would be negatively pressured. Is that when the door is open, outside air is allowed to go inside, but inside air is not allowed to go outside until it is specially filtered and exhausted, usually from some height. So that's negatively pressure. You don't want people to come in contact with contaminated air coming from a particle room. So if the door is open, the fresh air will go inside, but whatever air is inside can't just come outside. So that's what we mean by negatively pressure. So it's illustrated here. So you can have a room positive pressure, right? Which means that that's usually normal situation. You open a door and air can come out. When it is negatively pressured, come out, but fresh air is allowed to enter. And that dirty air which is inside usually is filtered and exhausted or extracted from the particle. Cohorting is a term we use, placing of patients with the same known pathogen in the same designated unit. So, for example, we all established COVID wards or COVID units where everybody with COVID was placed together. That arrangement is referred to as cohorting. Infectious respiratory aerosols, we have two types typically. We have droplets, which are greater than 5 microns in diameter. And we have droplet nuclei, which is less than or equal to 5 micrometers in diameter. So bear that in mind. In terms of the primary groups of biohazardous agents, of course, we have microorganisms and their toxins. We have arthropods. We have allergens and toxins from higher plants. We have protein allergens from both vertebrate and invertebrate animals. Right? So there's a lot to contend with. So these are some of the factors which affect exposure and infection, modes of transmission. Is it inhalation? Is it ingestion? Is it dermal absorption? Is it injection? Right? So there are many different modes. But in the occupational environment, when achieved, modes of transmission is inhalation. You either inhale microorganisms or you inhale toxic chemicals, right? And then the routes of entry, right? Infectious dose. So it's not just that you must be exposed to a pathogen. That pathogen must be present in certain quantities to be able to overwhelm your system and produce disease. Then there's agent viability and virulence. Right? Virulence relates to the ease with which a particular pathogen will cause a disease and at what rate. So some pathogens are much more virulent than others. And then there's a big question of host susceptibility. Many of us, for many reasons, are more susceptible to infections than others. There's a phenomenon of individuality, right? But certainly many people may have compromised system, they may have pre-existing conditions that will make them more susceptible to a particular infection than others. So with COVID-19, people with comorbidities were more vulnerable and at greater risk of getting more serious disease and dying. So let's look at biosafety levels, because especially in laboratories where workers have to work with all kinds of microorganisms, then they need to protect themselves. You take a blood sample from a patient and you send it to the lab. All they're interested in is the result, right? But in trying to analyze that sample, the worker may be exposed, right? So they have to take precautions. So there are 4 biosafety levels, and basically it's a classification of etiologic agents based on hazard, because some microorganisms pose greater hazards than others, right? So that's the whole thing behind biosafety levels. So there are 4 biosafety levels: BSL1, BSL2, BSL3, and BSL4. And as you move from 1 to 4, the situation gets worse. So at 4, you are dealing with the most dangerous pathogen you could think of, something like Ebola or smallpox. Whereas at biosafety level 1, you may be dealing with common cold and influenza that don't pose the problems that Ebola and smallpox will pose. So let's look at each. All right, so agents not known to consistently cause disease in healthy adults. So you can work on an oak bench top or whatever, right? And there are some examples there of some of the organisms. Bacillus subtilis, canine hepatitis virus, E. coli. So they would use biosafety level 1 when dealing with them. Biosafety level 2, these are agents associated with human disease. So there'll be limited access to those labs. You'd have biohazard warning signs and shafts precaution and all of those things. For level 3, there's potential for aerosol transmission. So you need primary barriers, you need physical separation like self-closing doors, in some cases double access door. Exhausted air is not recirculated, and negative airflow is required. So those rooms must be negatively pressured. And then you have biosafety level 4, where you're dealing with the most dangerous exotic agents which pose high risk of life-threatening disease. So in those cases, you may need to have primary barriers plus full body air supplied positive pressured personal suit. So as you move from level 1 to level 4, you need to take more precautions, and the sophistication in terms of personal protective equipment increases. So this slide summarizes the 4. Biosafety level 1 is at the bottom, and at the top you have biosafety level 4, where you deal with those pretty dangerous guys. In terms of routine and specific infection control precautions for acute respiratory diseases, we're going to be discussing 4 precautions. The first one is standard precaution, and this is routine infection control precautions that are applied to all patients in all healthcare settings. So when you say you practice standard precaution, you must do the things that are listed there. Pay attention to hand hygiene, right? Risk-based selection of PPE. So instead of using a mask as some of you are wearing now, you may need to use N95 depending on the risk, right? Respiratory hygiene, cough etiquette, all these are parts of standard precautions. Environmental control, so cleaning and disinfection of contact surfaces. Proper waste management, so you have your sharps container to contain your sharps which may be contaminated. You have other storage containers for less toxic waste. So standard precautions basically are a set of precautions that must be applied in all settings where you treat patients in whatever healthcare facility, be a health center, a hospital, or wherever. Right? There was a time when we spoke about universal precautions, but when the term universal precaution was used, it was used specifically in relation to bloodborne pathogens like HIV and hepatitis B and C. Standard precaution is a more all-inclusive term, where you take precaution to prevent any eventuality. And these are things you do normally in patient care. So those are standard precautions. So hand hygiene, personal protective equipment, wearing of gloves, gowns, masks, eye protection in some cases, and even face shield over your mask in certain situations. So you take a risk-based approach. This slide is just telling you how to handle with alcohol-based formulation. I don't know how popular that is here in Jamaica or here at UWI, but I know up north, the citizens are said to be busier than everybody else, and people don't have time to wash their hands, which I still think is the best approach to hand hygiene. So they will have some bottle of fast drying alcohol attached somewhere on their body, and in between sleep patients they will use this alcohol rub. While alcohol is effective, it is most effective on a relatively clean surface or a relatively clean hand, right? So depending on how contaminated your hands are, maybe just using alcohol may not be enough. You probably need to wash your hands and then sanitize your hands, right? In our culture, we are not averse to washing hands. As a matter of fact, we wash hands more often than people in other cultures, right? We bathe more often than people in other cultures, right? I'll tell you a quick story. I supervised some years ago a graduate program between UWI and University of Alabama at Birmingham and San Diego State University. And we used to stay at Preston Hall. And one morning, one of the guys came to me and was complaining that the water was too cold. I was saying to myself, how could somebody from North America come to Jamaica and complain about water being too cold? Anyway, I promised him that I would investigate it. And I saw him the following morning. And I said, how are things today? He said, I don't know, I didn't check. So he was telling me that he didn't take a shower that morning, right? So, so I'm just saying to you that we do some things really good in this part of the world. We wash our hands. We don't have a problem washing our hands. Some of us probably do it too often. 3-4 times a day. No, that's a bit too much, right? But in other cultures, people wait 2 and 3 days before they take a shower, you know. Right? Alright. So we have dealt with standard precautions. Then we are going to be looking at 3 different kinds of precautions now. So one is contact precaution, the other is droplet precaution, and the third is airborne precaution. Whenever you're going to adopt any of these 3 precautions, you must also incorporate into it standard precaution. So it's going to be standard precaution plus contact precaution, or standard precaution plus droplet precaution, and standard precaution plus airborne precautions. And contact precautions are taken in cases where, by being in contact, physical contact with a surface or a person, you can get infected. So for contact precautions, gloves and gowns and aprons are important when diseases can be spread through contact. Good? For droplet precautions, medical masks will be required if working within 1 meter, 6 feet, 4 feet of a patient, but advisable for any entry into a patient's room. So if you are seeing a patient who is suffering from a disease that is transmitted via droplet infection, then you need to wear your mask. And sometimes it may need to be more than a regular mask. And then airborne precautions are applicable in situations where you will need a respirator, example an N95. So if you're in a situation where you're treating a TB patient, then clearly you, the doctor, should be wearing your N95 mask, and the patient you're treating should be wearing a medical mask. The other thing to note is that you don't just get up and put on an N95 mask or respirator. One needs to be properly fit tested, because the purpose of having this respirator is to ensure that your face is as sealed as is possible. And so somebody who wears heavy beard cannot wear a respirator properly, right? And with COVID-19, I see all kind of innovations, how people wear the mask based on the amount of facial hair they had. And in a number of cases, what they were doing doesn't make scientific sense, right? It's like the fowl just run and hit its head, and because it cannot see you, it assumes that you don't see it, right? So remember now, the 4 precautions are standard precautions, and then you have contact precaution, depending on how the disease is spread, and droplet precaution, and the airborne precaution. These are specifically based on how the particular disease is transmitted. But in using any of these 3 precautions, you must also use standard precautions. So these 3 are added precautions to standard precautions based on how particular diseases may be transmitted. Alright, so that's a summary slide. So these are typical protective gears that you're going to be using. Eye protection, ear restraint, gown, gloves, surgical mask, N95 mask. The question is, how do you don? How do you put on personal protective equipment? In what sequence? And how do you doff them or take them off? And there are recommendations, right? So in terms of putting on or donning your PPE, well, the first thing you want to put on is your your gown, and then your mask, and then your other eye protection if that is needed, and finally your gloves. And there are also proper sequence of taking them off, which are illustrated there. And it is always advisable and recommended that you wash your hands before you put on the gloves, and you must always wash your hands after removing the gloves, and ensure that these things are disposed of in an appropriate container. For the self-fit testing of N95 respirator, it would be good if, as a group, people are trained into this fit testing, because basically what they would do is put on the respirator on you, and in some cases they spray in your breathing zone some awful smelling substance. And if you can smell it, it means that there is some leak, some point there which is allowing that chemical to pass through. So fit testing is important. One doesn't just put on a respirator and go and work. It must be fit tested. And you need somebody who is skilled at fit testing to advise or to train you. In terms of controls and exposure barriers, we can use engineering controls. We can use administrative controls. We can use good work practices and good housekeeping. And of course, there's personal protective equipment. So these are engineering controls. What engineering controls do is that they either isolate the hazard or remove the hazard from the workplace. So a sharps container, for example, is an engineering control because it safely stores the sharps so that you no longer come in contact with them as you go about doing your job. It includes ventilation, where you can exhaust contaminated air from a particular room, right? It also includes, for those who do work in the lab, like your fume hood or your biological cabinet that you work at. For administrative controls, worker education and training important, worker rotation. Sometimes a worker may complain that there's a problem, it may be an allergy or something. Then you may just need to put that worker somewhere else to work, right? Wearing of personal monitoring devices like monitoring for radiation, that's part of administrative control. And equipment maintenance, it makes no sense to have equipment in the hospital or elsewhere and it is not maintained, right? Your air conditioning system must be maintained, filters must be changed and cleaned, or you're going to end up with contaminated air, which can lead to sick building syndrome or worse, building related illnesses. So all of these things must be attended to. For personal protective equipment, remember that personal protective equipment do not remove the hazard. It just offers protection against the hazard. So the list is there. You need to have ample supply of personal protective equipment, and you need to use them. I've seen many cases, not necessarily involving doctors, but other workers. They get the personal protective equipment, and you know what they do with it? They get the water boots, and they sell it. They sell it, right? Other equipment, they get it and they sell it, and management does nothing about it. So supervision is another problem. Why would I, as a company, invest in all of these things and give it to you for your own protection? And you don't want to wear them? Worse, you sell it, you'd have lost a job, right? And then there are workplace controls. So there are many things you can do in your workplace that can reduce the likelihood of exposure by controlling the way certain tasks is performed. right? So hand washing is a work practice control, right? Handling of used needles, collecting and transporting fluids, right? There are protocols to do a number of things, and if these protocols are followed, then the possibility of exposure will be greatly minimized, if not totally eliminated. So these are some summary slides. You can read through them and just summarize what most of the things I've just said. And there are two additional slides where you're looking at biosafety cabinets, which are in different classes. So you may want to look at that. And you may establish your practice, and then you have a lab attached to it. And you have laboratory workers that have to get safety cabinets and whatever to work with, right? And then in terms of chemical fume hood versus biosafety cabinet, that's just a comparison. So as I end this lecture, the one thing I beg of you is to increase your awareness of occupational safety and health issues pertinent to your practice. And if you suspect, remember the precautionary principle we spoke about? If you suspect that something may be affecting you, report it. Ask for it to be investigated, right? And if you get personal protective equipment, don't forget that you're a superhuman being. Sometimes these equipment are uncomfortable to start with. You need some getting used to it. I didn't know I could be wearing a mask up to today. Because the first time I tried this thing, it wasn't easy, right? But I just want to encourage you that as you try to be the best doctors you can be aware of occupational exposures and don't let those get in your way. And worse, don't allow those things to get you sick, because the consequences could be great. Alright? So I'm going to stop here for today. I was trying to confirm whether your quiz will be online or face-to-face. I'm still to get a word on that. Yesterday I was trying to load a lecture onto the site, and it just disappeared. Anybody able to access the course site? It just disappeared from me yesterday, so I'm going to call the police to help me to retrieve